Thank you so much, Dr. Stevenson. I'll add a brief update of how we are utilizing optical genome mapping in rare disorders here at the Genetics Center. There are two primary cohorts that we are very interested in. The first is the neural tube defect cohort, in which we have investigated 110 samples so far. We have diagnostic findings in 10% of these cases and candidate findings in additional 21%. To put this in context, the cumulative diagnostic yield with conventional cytogenetic methods, chromosomal microarray, whole exome, and whole genome sequencing is approximately 8%. So we are very excited about the numbers and the findings that we are finding with this technology in this cohort per se. The second cohort that we have just begun to investigate is the undiagnosed disease cohort. This is further subdivided into two cohorts. The first is the prenatal cohort. These are ultrasound abnormal cases which are normal with standard of care testing, and we have incremental diagnostic yield in 2 out of the 17 cases investigated so far. The second is the constitutional disorders. These are cases which have whole exome sequencing plus chromosomal microarray or whole genome sequencing, and these tests are negative. So we have incremental diagnostic yield in 1 out of the 6 cases investigated so far. So I'll be sharing one case example each from these two cohorts. The first is the neural tube defect cohort, and the example that I'm sharing is that of a male with anencephaly, where optical genome mapping identified a small balance inversion that disrupts the RMND5A gene. Now, this gene has a PLI of 1 and is not associated with any phenotype. So we were very interested in this finding. Very interestingly, in the same cohort of 110 cases, we identified a case 2, a female with large posterior parieto-occipital encephalocele, which has the exactly same inversion that breaks the RMND5A gene. So the cumulative evidence that we have from the literature and model organisms strongly suggests that this is a new gene associated with neural tube defects. So as I said, we are very excited about what we are finding with this technology in these birth defects. I'll now jump to the second cohort, the undiagnosed disease cohort. And the case example I'm sharing is that of a boy, which is seen for the past 15 years here at the Genetics Center. So at birth, he had features suggestive of Down syndrome, and chromosome analysis on day 1 identified trisomy 21, so a molecular diagnosis consistent with Down syndrome. In the neonatal period, he had features consistent with that of Down syndrome. However, at age 7, he started having difficulties in walking. At this time, brain and full spine MRI were performed, which were not diagnostic for any disorder. And also, nerve conduction studies were undertaken, which again did not point towards anything specific. 2 years following this, at age 9, he started having progressive decline in his gait and having tremors in his upper extremities. At this time, the brain and spine MRI were repeated, which were normal, and the nerve conduction studies were also repeated. The nerve conduction studies did not again point out towards any specific disorder, but were suggestive for a polyneuropathy, for which a comprehensive neuropathy panel was performed, and again it was non-diagnostic. A year following that, there was progressive decline in his gait, and at this point he required wheelchair. Whole exome sequencing was performed, which was non-diagnostic, and exome level microarray was performed, which was also non-diagnostic. 3 years following this point, an hypertrophic cardiomyopathy panel was performed. Whole exome sequencing data was reanalyzed, both of which were non-diagnostic. The muscle and nerve biopsies were repeated. They were abnormal and pointed towards, again, a neuropathy, but was not diagnostic or pointed towards anything specific. 2 years from this point, the most recent visit, there were elevated troponin levels and neuropathy, and there were other deteriorating features. Again, extensive testing was performed, which included biochemical profiling, which was normal, SCA panel, which was normal, and the sample was submitted for optical genome mapping. The OGM identified a biallelic expansion in the FXN gene. Both the expansions were in the pathogenic range, which are consistent with the diagnosis of Friedreich ataxia. And we did confirm this with other methods, but I do not have the time to go into those. But this diagnosis of Friedreich ataxia fits the clinical features observed in this individual. So it ended the long diagnostic odyssey in this case. But what was very exciting is that beyond ending the diagnostic odyssey, just few months before this diagnosis was made, the first FDA-approved treatment for Friedreich ataxia was approved, the first that you see in this chart. And the clinicians are evaluating, and I was just recently told that this individual will be put on this treatment for Friedreich ataxia. So we are rooting for this patient and the family. With this, these are all the individuals that are essential to the projects that I just talked about, and in patient care and in the molecular diagnostic testing. So I'll stop there. Thank you so much for your attention.